Morning, everyone. I'm very happy this morning to introduce our first speaker, Dr. Gerald Feldman. Dr. Feldman received his Doctor of Medicine and PhD in Human Genetics from the Medical College of Virginia and completed his residency and fellowship in clinical genetics and clinical biochemical molecular genetics at Baylor College of Medicine. He is board certified as a PhD medical geneticist, MD clinical geneticist, and clinical molecular biochemical geneticist by the American Board of Medical Genetics. Currently, he holds faculty appointments as a professor with the departments of pathology, pediatrics, and molecular medicine and genetics, and is a clinical member of the molecular biology and genetics program at Wayne State University School of Medicine. Additionally, he is the director of clinical genetics services, as well as the medical director for the medical genetics residency program, medical biochemical genetics fellowship program, and genetic counseling training program at Wayne. He also serves as the medical director of the genetics laboratories at Detroit Medical Center University Laboratories and works as a clinical geneticist in the Department of Pediatrics within the Division of Genetic and Metabolic Disorders at the Children's Hospital of Michigan. He has been listed as one of the 100 top docs in Michigan and as well as one of the best doctors in Southeast Michigan on multiple occasions, and recently this year received the President's Award for Teaching from Wayne State University School of Medicine. Today he's going to speak to us about growing up in the genomics era, integrating genetics and genomics into primary practice. Please welcome Dr. Feldman.
Well, good morning. Thank you very much for inviting me. Thank the committee. It was a pleasure meeting Dr. Silbergleit last night. And thanks to Morgan. Morgan was one of our genetic counseling students at Wayne State University, so it's a pleasure to see her here and being successful in her own right. So today what I thought I would do would be to talk about what I see as the opportunities for individuals and physicians and patients as it relates to the way that genomics will be integrated into everybody's medical practice. So I have no conflicts to declare. And so my objectives are really to recognize the impact of the new genomic technologies on your patients and families and your practice of medicine. And so you might ask, well, how can I, from an academic position, be able to think what's important for primary care physicians? And so I hope by the end of this talk you'll see at least what my thoughts are about that. And so my goals will be to help with the recognition of when your patient may benefit from genetic testing, and then identify patients who may benefit from genetic services. And I differentiate the two of them in the sense of there may be some genetic testing that you might be ordering in your own practice, and there may be other patients who you might want to refer to a clinical genetic service. So if we look at the various applications of molecular genetic testing, and there are many more beyond what I've put on this slide, if we try to at least separate out inherited genetic or genomic tests from non-inherited genetic testing, we'll hear more about those separations later. But within the inherited genetic tests, I distinguish them into 4 different categories. There are tests that are used for diagnosis of a particular genetic disease. There are tests that are used for carrier screening, so screening couples or screening individuals who are contemplating pregnancy. And then we distinguish diseases in which there is a genetic test available to diagnose someone before those symptoms appear. And those would be called pre-symptomatic testing, and Huntington disease is the classic example of that. And then there are genetic tests that give one a predisposition or an increased risk to develop a disease, and we call those predisposition types of testing. Breast cancer testing, BRCA testing, for example, is an example of that, or some of the inherited coagulopathies like factor V Leiden would be a good example of that. You'll hear more about another area that has gotten a lot of press and a lot of publicity, and that's in relation to precision medicine, which primarily at the moment is related to cancer genetics, and you can separate those into both solid tumor as well as hematopathology. Infectious diseases and the microbiome, we'll hear more about that as well later. And then There's lots of genetic testing used for identity testing in terms of transplants or paternity testing, forensic testing. I will not be speaking about those today either. If we look at how we identify genetic variants, we've been doing that for a long time. What we're seeing here is not new in terms of ability to diagnose genetic diseases, but that the technologies have changed. And so if you look all the way back into the 1900s, it really was based upon what you could see under a microscope. And then we were able to, as we just remembered about Watson and Crick and the development of the DNA sequence and DNA structure, we were able to look under the microscope and look at chromosomes from a gross representation. And so that was really, if you think about it, the first use of whole genome analysis, right? You were looking at an entire chromosome, and the technologies for that evolved over time, and molecular technologies came into place in the 1980s or so, revolutionized by a test called the polymerase chain reaction. Some additional chromosome-based testing, looking at fluorescence in situ hybridization, or FISH testing. And then the advent of DNA sequencing to actually allow the sequence of an individual gene to be identified. The technology for that was a little bit challenging at the beginning, has evolved over time so that sequencing has become much more reasonable. And it wasn't until really in the last 15 years or so that technologies advanced enough that we could look beyond just individual genes and look at beyond individual DNA sequences and look at the entire genome, and using technology we call next generation sequencing. So I'll talk a little bit more about that as well. What's the purpose for genetic testing? What's one of the major things that we think of, at least from a pediatric perspective? And that's to end the genetic odyssey. And that's to end the odyssey of a patient not having a diagnosis and going from physician to physician or from test to test. While we think of genetic diseases as quite rare, in fact, if you look at all of genetic diseases together, they're relatively common, affect about 1 in 50 individuals if you put them all together. But up to about 50% of them never receive a diagnosis. And so, as I said, patients embark on this genetic odyssey where you might have had experience with some of these patients where they go from place to place, multiple tests, multiple imaging studies. And it's a slow, very costly adventure, very frustrating for patients, very frustrating for families. Oftentimes, the diagnosis may not even be correct at the end of that process. And we have many examples of patients receiving inappropriate care because they have a wrong diagnosis. And so for many, the new technologies allow for a molecular diagnosis which ends that diagnostic odyssey. Now, there's also been a paradigm shift in test utilization, and there's a lot of talk at many different hospital processes about test utilization. But think about how genetic testing has and been in the past and where I think it's going in the future. Genetic testing was typically ordered by a clinician, mostly a geneticist, and it was primarily a single gene test where you were looking, you suspected a particular genetic disorder, you ordered the test for that particular disorder, and your clinical acumen may or may not have been correct. Genetic testing was also ordered by oncologists or pathologists, again, based upon that particular type of tumor. And the data that was generated was relatively small, relatively limited. You were looking really at that particular gene. And now as we move forward into the new technologies, it's potentially available for all clinicians to begin ordering testing. And the tests that I'll speak mostly about today will be gene panels, so where we're looking at a group of genes that somehow have a connection, or whole exome sequencing, where you're looking at all of the coding regions of all of the genes at the same time. And then not so much in the future, I guess, anymore, whole genome testing, where you're actually looking at all the genetic information and sequencing all of that. And so we're changing our process from really a clinical suspicion to a phenotype-driven diagnosis where you might suspect a particular global situation, developmental delay, autism, intellectual disability, things like that, where you can order a genetic test to look at that phenotype as opposed to a specific syndrome. So that specific diagnosis isn't necessarily available or suspected even at the present time, but you can test for a phenotype. Now you can imagine the amount of data that's collected when that happens. So a large and complex database for each patient, for each test that you're generating, and that leads to a whole other set of discussions based upon what do you do with that genetic information. So if you think about genetics in primary care, again, this is not something that I'm saying is new because genetics in primary care has been done for a long time already. If you think about testing like newborn screening, for those who are pediatricians or family practice doctors, newborn screening has been around since the 50s or 60s, right? And so that's a genetic test. The genetic test for PKU that most of you are familiar with is a genetic test. If you think about testing for a syndrome like Down syndrome, the chromosome test for that has been available since the 60s. Taking a family history, many of you do that in your practice already. And I'll talk a little bit about family histories because some people think it's an onerous task, and I'll tell you that in general, a three-generation family history, which some people think is necessary, is really not for trying to get the information you need. And then already looking for red flags. So that's something I think is done in every practice. So what I'd like to argue is that the expansion of genetic testing is the real conundrum, not really genetic testing per se. So I think genetic testing always seems to be put in a separate category of something that's rare and exclusive and difficult, but in fact, if we think about genetic testing, it's been done for many years. So what I see as the roles for a primary care provider are to recognize features of genetic diseases, recognize features of genetic conditions such as cancer that have or may have a genetic component, and identifying those individuals who might value from genetic services, either a referral or by having genetic testing done. And really the key is to try to decide which one of those can be done within your own practice or which ones require additional genetic services. And then monitoring the health and coordinating the care of those patients is part of what I would think of as being the medical home, and looking at all of the issues that are particularly relevant to that particular disorder, and then providing basic information to the patient in regards to that genetic disorder. Now, saying that is different than reality, and none of these really account for the comfort level of the primary care physician. In other words, what is your particular knowledge of the right genetic test to order? What's your knowledge of where to send that test to? Where's the best lab to send that to? What's the difference between the various labs that offer, quote unquote, the same genetic test? There's a myriad of insurance issues that relate to genetic testing. Again, genetic testing seems to have been put into a category different than many other laboratory or radiology-based tests, so it requires some more extensive types of pre-authorization. And then the question is the ability to interpret and explain that result to the patient. Is that something that you feel comfortable with? Or again, is that something that you would refer to a geneticist for a more thorough explanation? So let's talk about a particular case study. This was published in PEDS a couple of years ago. And so we'll walk through this case as it relates to, I think, your comfort level and the kinds of things you might expect to see coming down the road. So we have a 13-year-old girl who comes into your office as a new patient with a history of fainting while playing soccer earlier that day. She had no warning and just went down. She has abrasions on her forehead and knees, but otherwise feels well. A focused family history, that's what I was talking about, really looking at the issue that relates to the reason why your patient came in to see you. Focused family history revealed the patient's mother had a number of fainting episodes as a teenager, but none in the past 20 years. Patient has a sister who's 11 years old who is well and had a brother who died of sudden infant death syndrome at age 8 months. Her maternal grandmother died at age 36 due to heart disease. So focused history, it's 3 generations as we're talking about, but really you're focusing on the reason why that patient came to see you. EKG was obtained and revealed a QT interval that was the upper limits of normal, but just overlapped with long QT syndrome, and that's the abbreviation for that. When the reason for doing an EKG and the equivocal findings were related to the family, the mother offered additional family history. Everybody okay so far with thinking about seeing this in your own practice? So the additional family history, now that you have a focused family history and now that you know what particular questions are going to be relevant to this particular discussion, there's a male cousin who was born at 33 weeks gestation, spent 4 weeks in the NICU. He suffered a number of events requiring resuscitation and had a similar EKG that was inconclusive. Although the pediatric cardiologist felt the EKG was not likely an issue, his neonatologist insisted on molecular testing for long QT syndrome, and it was found to be negative. Everybody okay so far? And here's the original laboratory report on the cousin's genetic testing, and look at the date. This is key if you're going to be thinking about genetic testing. It was performed in 2002, revealed the following result: no long QTS mutations detected. So what does that really mean? This is a test from 2002. At this point, are you still comfortable with thinking about what's going on in this family, or would you be considering a referral to a geneticist? So let's backtrack a second and think about the different types of genetic testing, and let's think about what test was available back in 2002. One type of genetic test is a single mutation in a single gene. So if you're thinking about a genetic disorder like Fragile X syndrome, and these are just examples, or sickle cell disease, one common mutation causes that disease. There's a simple genetic test that can identify whether a patient has sickle cell disease or not, right? If you're considering a diagnosis like cystic fibrosis, for example, there are over 2,000 different genetic changes in the cystic fibrosis gene that cause that disease. And so the test for that is not to look at a single common mutation, but to look at either a panel of mutations or to do DNA sequencing of the entire gene. So there are panels of mutations, and the number of mutations tested varies from lab to lab. So that's a key piece of information of what laboratory provides the best service. And then if you're going beyond, let's say, sickle cell disease and thinking about mutations within the beta globin gene, then DNA sequencing to look for disorders that cause beta thalassemia are going to be required to look for that, and not a single mutation test. So if we go back to this case, we don't know what test was done, but presumably in 2002, it was for a single gene, probably done by DNA sequencing. And so has anything changed since that original test was performed? And the answer to that is absolutely yes. There are many more genes that cause long QT syndrome that have been identified, and if you look at the most recent set of tests that are available for testing for long QT syndrome by itself, at least 17 different genes now are known to cause long QT syndrome. So as you test for more and more genes, it becomes very cumbersome and less cost-effective to test each gene individually. If you can think about testing by DNA sequencing of each individual gene, let's say for long QT syndrome, 17 different genes, that's a challenge. And that brings us to the technology that's here today, and that's called next-generation sequencing. And it's a modern, high-throughput sequencing technology where you're sequencing millions and millions of fragments of DNA from one particular patient. And it's being done simultaneously. You're sequencing all of the different genetic regions at the same time, and that's why you might have heard the term massively parallel being used for next-generation sequencing. And then what happens next is that those fragments are mapped to a reference genome, what's the normal genome, and it's used to then identify what's not normal. I'm going to try and show you a video of what, in a simplified form, next-generation sequencing is like.
This is Neo. This is Neo. And I'm going to teach you about next-generation sequencing alignment. Normally, nucleotides are called A, T, G, and C. But that's boring, so instead we're going to use
Okay, everybody got next generation sequencing now? So really, while that's a very simplified approach, it really tells you what's happening in next generation sequencing, and you're doing that not for that little piece that they're showing you in this animation, but the entire genome can be done that way, where a computer is going to line up all of the different sequences that have been fragmented and then sequences and put them in order, and then compare them to the known normal reference genome that's out there, and then you can identify what's different from that. And that's really the underlying process of next generation sequencing. Now, there are two types of next generation sequencing, or at least I like to separate those into two parts. One are called targeted gene panels, where you're doing sequencing of multiple genes that cause a similar phenotype. So this goes back to the long QT syndrome, or you could use it for autism panel or intellectual disability, cardiomyopathies, any type of phenotype in which there are multiple different genes involved. Targeted gene panels are less expensive than whole exome sequencing, and they have an increased sensitivity because you get better coverage of the genes that you're particularly interested in. And so that's what you really heard about when it says depth of coverage. There's also whole exome sequencing, and I'll talk a little bit about that. And then, as I said, what's now coming into the forefront is whole genome sequencing. So why would you think about whole exome sequencing? What's the reason why we're sequencing just the exons? And the reason for that is that you only have to sequence about 1% of the genome, which is where the active coding regions are of the genome. And that will identify about 85% of known pathogenic variants that are in those coding regions. If you look at data that's been presented so far in multiple different studies, in a previously undiagnosed patient, you'll identify the underlying cause in about 25 to 30% of the time. And so that's a pretty significant yield for this particular test. It's different than whole genome sequencing in the sense that whole genome sequencing is theoretically sequencing the entire genome, so the introns and the exons. And it's now being introduced into clinical testing. There's still some questions about whether that will replace whole exome sequencing, but the underlying thought is that over time it probably will. So how do we determine whether or not that variant that we find is pathogenic or not? So there's lots of different ways to look at DNA variation. There's variant databases that are either population-based or databases for particular diseases, where everybody who's testing for that particular gene would submit their information to a database that's accessible to other laboratories and other clinicians. There's a number of software prediction programs that help determine pathogenicity, but remember, they're just software prediction programs. There's ways of looking at whether that particular genetic change has been evolutionarily conserved. It's thought to be, if it is conserved, that it's more important, and so likely would be pathogenic if there's a variation in that particular sequence. You can look in PubMed, looking for publications of particular genetic changes. There's ways of looking at functionally whether or not a particular genetic change is pathogenic or not, see whether or not there have been other patients reported with that same genetic change. And at last resort, you can always Google and see if that mutation's been described somewhere. But in the end, you may be left with a variant of uncertain significance, and that's called a VUS. And the question always is should they be reported by the laboratory? And then how does the clinician follow up on them? In addition, when you're doing genetic testing, looking at, say, whole exome sequencing, you're going to find changes in other genes that may be not part of that phenotype for which you ordered that test. That's not unique or new to medicine as far as I'm concerned in terms of secondary findings, although again, genetic testing has been singled out as being somewhat different than other tests. But if you think about this example, a patient referred for a chest x-ray to rule out pneumonia. The radiologist identifies no pneumonia but notes an anterior mediastinal mass. Should that incidental or secondary finding be reported? Of course the radiologist is going to put that in their report, right? That wasn't the reason for the x-ray in the first place. The same thing when you think about genetic tests. So there's similar issues with genomic testing. The whole exome sequencing might identify a pathogenic variant in the BRCA1 gene, the breast cancer gene. And it might be in a patient who's 10 years old, referred for intellectual disability. So should that secondary finding be reported? So we're looking at lots of ethical questions when it comes to genetic testing as well. So the American College of Medical Genetics, which I'm very involved in, so I guess that is a disclosure, had published a list of minimum list of actionable genes that says that you should report pathogenic changes in those genes if you identify them as a secondary finding. And the genes that were selected were those that had a significant potential for preventing disease morbidity and mortality if identified in the pre-symptomatic period. And these included such tests as hereditary cancer genes, Marfan syndrome or syndromes with particular lethality, cardiomyopathies and arrhythmias, familial hypercholesterolemia, malignant hyperthermia, and others. And the recommendation was that those should be reported regardless of the clinical indication, and that additional genes may be analyzed for incidental variants based upon parents opting in or opting out of wanting additional test information, but that should be done prior to the test being performed and only with informed consent. For these actionable genes, the college recommended that these be reported regardless of a patient's age. If you think about the BRCA1 gene identification in a 10-year-old, it may not have implications for her health at that particular age, but could clearly have implications for that patient's mother or father if one of them is carrying that genetic change. The other issue that relates to next generation sequencing I touched on for a second is the data that's generated. It's a large amount of data. It requires lots of interpretation as well as storage of that information. There's lots of issues about how long to keep that data, how long does it have to be stored for, who has access to that genetic information, and who should be able to use that information at a different time period in that particular patient. So let's go back to this case study. The pediatrician consulted with the medical geneticist at the nearby tertiary medical center, recommended retesting because a number of new mutations had been reported in the past 8 years. And here's the new result, the long QT syndrome panel, so they ordered a panel. It found a mutation in this particular gene, and this mutation is reported as an uncommon cause of long QT syndrome, but it was reported after that initial test was performed. And so there we have the underlying cause of this disorder, of the etiology of that disorder in this particular family. So here's just, and obviously nothing to think about more than just, here's the panel that's currently available for long QT syndrome, and the mutation that was identified is highlighted in yellow. It's one of those genes that's tested for in that 17-panel gene test. Long QT syndrome is an autosomal dominant disease, typically presents with syncope, but can manifest as sudden cardiac death. And this family was referred to both then a pediatric cardiologist as well as a medical geneticist for extended clinical evaluation, genetic counseling, and molecular genetic testing. And then within this particular family, the testing identified the same mutation in her mother, her cousin, and her uncle. And remember, I gave you that family history beforehand. The family and the patient are now doing well. All patients previously identified with this particular genetic change are taking beta blockers, and one patient has an implantable cardioverter defibrillator. So I think this shows the value of taking a good family history, thinking about genetic testing, thinking about what's changed over time, thinking about when to refer that patient, and then thinking about how to help other family members as well once you identify that genetic change in one family member. So we hear a lot about fake news these days. So I thought I'd give you a couple of things that are misnomers out there. We talked a little bit already about how genetics just deals with rare diseases and the diagnosis is only a label. When we think about genetic diseases that are quote unquote rare, sickle cell disease affects 1 in 500 African Americans. If you look at something like neonatal sepsis, has the same incidence. Nobody would think about neonatal sepsis as being rare. Rare genetic diseases like cystic fibrosis versus meningococcal disease has a much lower incidence, but people still are concerned about meningococcal disease, right? And may vaccinate for that. And so rare genetic diseases are not so rare when you think about them in that context. And so there are many reasons for genetic testing and genetic referrals. The key is to identify those reasons and think about things like prognosis, anticipatory guidance. There's now many new treatments available for genetic diseases. I think that's the most exciting part about being a geneticist now is new treatments are coming in relatively quickly. And you can also think about this as it relates to future reproductive planning, risk for future offspring, family planning activities. Testing is too complicated and too expensive. So I put a list of some genetic tests compared to some non-genetic tests, so you can see that testing is pretty much in line with other tests that you might routinely order. So if you look at thyroid function testing, for example, it's in the same range as ordering a plasma amino acid test if you're looking for a patient with an inborn error of metabolism. A karyotype costs about $700. That's in line with an MRI, which costs anywhere from $1,000 to $1,500. So a single gene test now is in the same range for that type of cost. A chromosome microarray looking for copy number changes or microdeletions or duplications costs about $1,500, again in the same range as an MRI. And if you look at whole exome sequencing, the range is somewhere around $3,000 or so, $3,000 to $5,000, and the colonoscopy is in the same range. So genetic testing, again, gets singled out as being quite expensive. Many hospitals are looking at their lab utilization related to genetic testing, but it's really in the range of what other medical tests cost. But the key is to make sure that you order the right test and ask for help. We have a genetic counselor in our laboratory that routinely looks at the genetic testing being ordered at the Detroit Medical Center, and I can't tell you how many times she's identified the wrong genetic test being ordered, either the wrong gene, the wrong laboratory, the wrong test completely, and as documented in her database, she's probably saved the Detroit Medical Center about $100,000 a year in tests that were needlessly being ordered, and she found a better way to do that test or get that test ordered. So many hospitals are now doing the same thing, and there's data published about that from other systems as well. And then I think one of the other things that often I hear is that the geneticist doesn't need my help to manage a patient from the primary care perspective, and the truth is that the medical home plays a crucial role in these patients. It's important for the patient to have a primary care physician. Most geneticists don't provide primary care, but we're great collaborators. And then we've talked about collecting family history is taking too long, but the reality is the studies show it takes about 3 minutes to take a family history of the existing patient and 6 minutes for a new patient. It helps if you complete those forms ahead of time, the patient completes those forms ahead of time, and this can prevent serious consequences of missing something in one's family history. So is genetic testing indicated? The questions you need to ask are, does my patient need genetic testing and will be applicable to their patient care? There are both medical indications as well as decision-making indications for the family. And then who in the family needs to be tested? Is it your patient that needs to be tested, or do you want to test an affected family member in that family? Let's say the patient's at risk for a genetic disease, but it's somebody else in the family who's affected. If your patient is unaffected, it's oftentimes, if available, important to test the affected family member first, because that helps you to know what to look for in your particular patient. And so when should you refer a patient for genetics consultation? I think it should be when your knowledge base or comfort level is exceeded, when the testing is complex and you're unsure of the testing strategy. Sample handling can be an issue, maybe too complex to take place in your office. You don't have the time to complete these extensive consent forms that are required for some of the genetic tests. And that the family might need genetic counseling regarding lots of information about that particular disorder. So my recommendations are to develop a strategy for incorporating genetic testing into your practice. You need to anticipate this influx of genetic information, including, and some of you may have had experience with this already, direct-to-consumer testing results brought in by the patient. That's happening in our clinic as well, so I suspect that some of you may have experience with that. And I think it's important to become adept at interpreting this type of information and deciding when to refer. Recognizing the social, ethical, and legal implications of testing children for adult onset disorders, for example, or direct-to-consumer testing. Are you prepared to help your patient interpret those results? And that's a challenge for everybody, and will be more of a challenge down the road. It's important to identify the correct test. We just talked about genetic test utilization. Identify the appropriate laboratory. There are lots of ways to identify a laboratory. Determine if it's a covered benefit. As I said, genetic testing is singled out oftentimes by insurance companies as not being a covered benefit. Familiarize yourself with the test interpretation and be ready for questions related to the test if you do go ahead and order that test yourself. And be able to reasonably explain both the test as well as the test results. So in summary, with the growing number of resources for genomics in primary care, the primary care provider must increasingly integrate genetics and genomics into their daily practice. And we talked about that patients are requesting genetic testing information, bringing in results from direct-to-consumer genetic testing. We must all be prepared for that down the road. And I think that primary care physicians are uniquely positioned to utilize genetic information throughout the patient's lifetime, from the process of screening or predictors of drug response, cancer prognosis, cancer treatment. We'll hear more about those later. And that this collaboration between geneticists, primary care physicians, laboratorians, and payers are necessary to effectively utilize genomics to produce the best benefit, the most benefit for patients. And here's a quote that I saw from, you can see it's back in 2010. Whatever the ultimate fate of healthcare reform in the US, whatever the limitations of genome-wide association studies, whatever loopholes exist in the Genetic Information Non-Discrimination Act, objections to medical establishment, offers to the concept of the masses obtaining their genomic information, no mistake, make no mistake, the genomes are coming. Thank you.
Questions for Dr. Feldman?
Sure.
So, great talk.
Thank you.
So, in 2002, genetic study was done, and it was negative, right? So, in 2017, medical knowledge is evolving, and you do a panel of 17, and you found a gene.
Mm-hmm.
But what if you had not found a gene? What do you do in 2022 when there are now instead of 17 conditions, there are now 23 conditions? How often do you retest, and is it practical to keep a registry of people who have negative testing to know whether you should or should not bring them back in for the latest and greatest?
Yeah. So that's a challenge that we face all the time in genetics. If you, even going back to when chromosome microarrays were first made available for the public, they evolved over many years so that they were identifying many more and more genetic changes. The same thing holds true for genetic tests. I think that's when a referral to a geneticist is probably a good idea. They can look to see what tests were available then, what tests are available now. And it may be that the technology evolves such that people are going to have a whole exome done instead of looking for a panel in 5 years from now. We don't know. But if you're looking at the entire exome or entire genome, then you don't have to worry about panels down the road. The advantage of panels is that, as I said, they're more succinct and and provide better coverage. But I think that's going to change over time as well, and you'll see that it may be more routine to order a whole exome as opposed to looking at panels that have one more gene added or two more genes added from the last one. Yes, sir.
That patient was in 2012.
Hmm?
Since 2012 to now, have you identified more genes in that?
Yeah, no, that's a good question. So what I showed you with the current panel of long QT syndrome is the current panel that's out there for available for testing. So that hasn't changed over the last few years. Yes, sir.
John, could you comment on the testing that's commercially available online, both the genealogy testing and the medical screening testing, which is apparently purchasable or can be obtained by genetics clinics at university that are looking to screen people and then send
Yep.
the results with no counseling attached?
Yep. Right, so that's a number of questions I'll roll into. One, there are a number of commercial companies out there who are offering what we call direct-to-consumer testing. The ones you might have heard of are Ancestry.com. You see a lot of commercials for them, 23andMe. They offer different types of tests. Ancestry is primarily looking at genealogy. So it's looking at comparing your DNA to the millions of people that they've looked at based upon ethnic background and racial background and country of origin. So they don't provide much in the way of health information. They really are ancestry related. But companies like 23andMe provide some medical-based information. Some are very straightforward and simple. Some have more significant prognostic health implications. It's a challenge because each of those companies offers a different set of tests that they're offering, and primarily they're risk-based estimates, so risk of Alzheimer's disease based upon ApoE, for example. That's just a risk. It's not a diagnostic test, and so you have to be careful in separating out risks, which is what these tests offer, versus diagnostics. And the FDA has come down hard on some of these companies for providing medical-based information. They've now loosened a little bit about what the FDA is now allowing companies like 23andMe to do. The American College of Medical Genetics has a policy statement that talks about what we think are relevant information for someone to do in those circumstances, and I think that one should be careful with the information that's available by some of these companies, and they are being provided without formal genetic testing and no physician ordering the test.
In our office to identify people who will be at risk for pharmaceutical complications.
Yeah. So that's a growing area. I think it will become much more prominent as years go on and we understand more about the actual risks and the relationship between pharmacogenomics and the particular drugs. I think it will become much more routine, but physicians need to be on board with the results and act on those. And so, for example, there's been data for years that suggests that if you look at one's genotype before prescribing Coumadin, that you will get lots of information about the dosage to use and prevent complications and prevent severe adverse reactions. But that's been a relatively poor uptake by the physicians who feel historically that they've been able to manage patients' Coumadin dose without that genetic information by trial and error. And so there has to be an uptake by physicians to be willing to utilize the genetic information, and the genetic information has to be provided back to you in a reasonable time to act on it.
I struggle with the clinical benefit of the genetic testing. Even in the example you provided, I think maybe the child would have seen a pediatric cardiologist and already gone on beta blockers. As an otolaryngologist, I face children with hearing loss, and identifying the cause of the hearing loss won't necessarily impact how I treat the patient. And furthermore, if the family is no longer having kids, and these kids aren't at a point where they're in childbearing age, things are going to change 20 years from now. So getting the testing now in that situation makes no sense.
Yeah, that's always the argument about what is the value of genetic tests and what can that test information provide. And I think the answers are really what we just discussed. Anticipatory guidance, identifying other family members who might be at risk but haven't been identified, and that there may be particular treatments available for certain types of genetic diseases that wouldn't be otherwise available without that genetic test to confirm that diagnosis. So I think that we have to start thinking beyond that particular patient and a particular way you're going to treat them anyway, to think about, are there other drugs that might be available for a particular genetic change? Cystic fibrosis is a good example of the particular genetic change has specific drugs that are targeted to those mutations. If you don't have that genetic testing, you know the patient has cystic fibrosis, you can't treat that patient with that particular drug, which is only approved for specific types of mutations. So I think there are lots of reasons why genetic testing has value beyond what you were mentioning.
So Dr. Feldman, the question now. So the insurance company doesn't cover this test, or some of the insurance company cover this test?
Yes. So it varies by insurance company, and it varies by your particular insurance plan. So you have to look very closely at what if it's an employer-based insurance, what that particular employer has contracted to. So maybe the Blue Cross covers genetic testing, but your particular policy excludes genetic testing. So it has to be both on a global perspective as well as what your individual policy says. Some do cover genetic testing, some don't. Some require pre-authorization with approval that requires genetic counseling prior to ordering the test. Some require that test be reviewed to make sure that it's the appropriate test. But there are some situations where yes, the company excludes testing either because it's not a covered part of their policy, or because the insurance company finds that particular genetic test to be experimental. So two different reasons why it's excluded, could be excluded.
That was a superb presentation.
Oh, thank you.
Oh, thank you.
Thank you.
Thank you, Dr. Feldman. I really appreciate thank you for your excellent talk, okay?